Hello, Exohana. My name is Damon Young, Vice President of National Partnerships. The purpose of this training segment is to provide a brief overview of the health insurance market, employer funding mechanisms, why we're moving into the payer space, and why we're collaborating with Aetna. 54% of the US population has employer-based medical insurance, also referred to as commercial insurance. With about 332 million people in the US, this means that over 179 million people have medical insurance. The balance of the population is covered by Medicaid, Medicare, individual, and military benefits, while approximately 8% of the population is uninsured. The 6 largest commercial medical insurance companies are Elevance Health, formerly known as Anthem, which owns a number of Blue Cross Blue Shield plans across the United States, United Healthcare, Aetna, Cigna. These first 4 are publicly traded companies, so we have access to their membership data by line of business. The last 2, Healthcare Services Corporation, which owns Blue Cross Blue Shield plans in 5 states, and Kaiser Permanente, are private corporations. So we don't have a line of sight into their commercial membership data, only their total membership data. So let's talk briefly about employer funding mechanisms. Employers select between fully insured medical benefit products or self-funded medical benefit products. Let's compare the two. First, who holds the risk? In the fully insured scenario, the insurance company holds the risk. Their goal is to spend no more than 85% of premium revenue on medical expenses so they can make a profit and cover their operating expenses. In the self-funded scenario, the employer holds the risk. Unlike insurance companies who need to make a profit, an employer's goal is to not exceed their annual medical benefit budget. Who pays the claims? Insurers pay the claims for fully insured products. Employers or third-party administrators pay the claims for self-funded products. What does the employer pay for? In the fully insured scenario, they pay for bundled products and services, standard benefits, inclusive of all services offered by a health plan. In the self-funded scenario, employers pay for a la carte products and services. The employers effectively operate like their own health plan. And to mitigate the risk of any catastrophic claims loss, self-funded employers purchase stop loss, which provides reinsurance coverage. States have regulatory oversight over fully insured plans, and a federal law called ERISA, the Employee Retirement Income Security Act, has oversight over self-funded plans. Lastly, we typically see smaller companies opting for fully insured products and plans due to the financial predictability, and larger companies opting for self-funded products due to the ability to customize benefits, control cash flow. They're not subject to state mandates which govern fully insured plans, and they don't have to pay state health insurance premium taxes. So why are we moving into the payer space? We have proven over the past 12 years that our clinical model works. It reduces total cost of care, it engages members, and it drives a great member experience. However, the model coupled with a commercial advantage plan design, which is a crossover line benefit, can drive even better results and better outcomes. We're collaborating with Aetna on a benefit called Aetna Advanced Primary Health, which is the commercial advantage plan design Scott and Nate have been evangelizing for years. Value-based care and reimbursement models continue to be tested 12 years after the Patient Protection and Affordable Care Act was signed into law. Productivity-driven healthcare, a la fee-for-service, remains in the foundational DNA of most providers' business and clinical models. In order to bring crossover's goodness to the masses, we need the right payer partners. Payers continue to evolve into the provider space to control total cost of care, but their medical benefit products and strategies are not differentiated. We know that a product with broad reach and one that can build strong consumer loyalty will win over time and provide demonstrable value. And we found a partner who truly believes. Aetna knows that our proven fixed fee clinical model is unmatched, and Aetna Advanced Primary Health benefit, coupled with our services, complements CVS Health's primary care strategy, inclusive of Minute Clinics and Health Hubs. We're starting small in Aetna with a 2-year pilot in Seattle, Washington. We're learning how to grow together, engage members together, and reduce costs together. Employers with over 50 employees will be targeted with the Aetna Advanced Primary Health Benefit, starting off with self-funded employers, which represent about 90% of Aetna Washington's commercial membership. These employers must opt into the benefit, which means they need to be sold and they need to agree to add the benefit. Over time, we will also have access to Aetna's fully insured membership in King County, Washington, which encompasses the Seattle MSA. There is no sales effort involved with fully insured employers. Aetna will automatically add the benefit to their fully insured clients' coverage. The benefit sits over top of Aetna's open access products and provides no cost, low cost access to our services. The benefit will be available starting on January 1st, 2023, and employers with the benefit will have access to crossover starting on their medical benefit effective date. We're excited to start with 2 near-site centers, one in the Westlake neighborhood of Seattle and one in Bellevue. And we're pleased to share that our first Aetna Advanced Primary Health client is Brooks Sports, a true health activist employer with 900 Seattle members, 2/3 of whom reside within 10 miles of the 2 near sites. To learn more about the value-based care model and how we generate revenue, check out Ben Hughes's VBC video. Thanks for your time, and please do not hesitate to reach out if you have any questions.